this week's Journal Club. We are today going to be reviewing a paper titled The Classification of Radiographic Lung Pattern Based on Texture Analysis and Machine Learning. So this is a study that was published in the Journal of Veterinary Science in 2019, and the aim of the study was to evaluate the feasibility of using texture analysis and machine learning to distinguish radiographic lung patterns, and further to determine useful texture parameters for discrimination of the four specific lung patterns, and to develop a predictive model that distinguishes those lung patterns based on some selection parameters. So the motivation for this study is stated clearly in the introduction, and that was that lung disease pathologically alters lung tissue and usually changes the opacity of the lungs in radiographs. Depending on the tissue affected, a characteristic lung pattern is obtained. Accordingly, classification of the observed lung pattern is very important for the differentiation of lung diseases in thoracic radiography. So the authors were really trying to see if their machine learning algorithm was able to differentiate those lung patterns based on some training data. So this was a cross-sectional observational study. It involved taking 1,200 regions of interest from a large number of cases. There were just over 500 of them, and there were lateral-medial and ventrodorsal thoracic radiographs, which had been collected over a 6-year period from 2010 to 2016 at the authors' institute in Korea. So the patient population was made up of 252 dogs and 65 cats. And these images, or more specifically these regions of interest, were then subjected to a batch of different tests based on 8 different texture analysis methods. And those tests then produced a large number of parameters that allowed the authors to extract relevant textural features on which they were then able to apply the machine learning algorithm. Subject inclusion and exclusion was decided upon by the study authors, 3 of the 4 authors who are veterinary radiologists. However, very little information is given about the criteria specifically for patient selection or inclusion from that database. So there's no information provided as to what percentage of the thoracic radiographs that were taken in that time frame are used. The inference is that all of the available thoracic radiographs where both these views were included were used, but it doesn't specifically say so anywhere. So 6 regions of interest, or 6 anatomical regions, I should say, specifically the right cranial, right middle, and right caudal lobes, cranial segment of the left cranial lobe, and caudal segment of the left cranial lobe were used for the ventrodorsal views, and then 2 regions only were used for the lateromedial radiographs, so specifically the cranioventral and caudoventral lung fields. Those regions were then classified by the radiologists as either being normal, alveolar, bronchial, or unstructured interstitial lung patterns. We'll talk in a little while about lung patterns that were excluded, but the 4 that were actually included for the purpose of this study were these 4. It's worth noting that they were using radiologist opinion as the gold standard in this particular instance. So what we're really doing is comparing the machine learning algorithm's performance to the radiologists. Lobes that were classified as having mixed lung patterns, i.e. more than one of the above, or including some of the lung patterns that were excluded from the study. And similarly, any radiographs for which the radiologists were unable to agree on which lung pattern they felt was present, they were excluded as well. It's unclear as to whether exclusion of particular lobes in this way may have introduced any degree of bias. Specifically on each of these radiographs, then the regions of interest to be used for the machine learning algorithm were then picked by just one of the authors, one of the radiologists, and they were selected by taking the maximum rectangular area that they could within an intercostal space, but that did not include any rib tissue, and with a minimum size of 30 by 30 pixels. In addition, no more than 3 regions of interest were selected per lobe, so that there wasn't over-representation of a particular pattern. And also, all of the lung patterns, all of the categories of lung patterns, so those 4 classes that we discussed a second ago, were represented with the same frequency. So there were 300 of each, and that number was selected because that was the number for which they had the minimum. So some of the lung patterns were represented by more than 300 regions of interest, but they were excluded to ensure that there was an even number of each lung pattern, again in an attempt to make sure that the training data for the machine learning algorithm wasn't biased towards a particular pattern. Male-female split between the study population was pretty much even, so 162 males for 155 females. It's not made clear how that split within species groups, so dogs and cats. So again, potential for bias there. If, for example, there were lots more male cats than female cats, but lots more female dogs than male dogs, that's not made clear. However, if we ignore that species difference, there is a pretty even representation of gender. Mean age for the study group was 8.3 years with a standard deviation of 4 years. It's a reasonably large standard deviation. The other thing is that it's not clear what the minimum and maximum age were, so it's possible that we have an overrepresentation of a particular age group here, either older animals or younger. The average or the mean number of pixels for each ROI was 1,914 and a bit, with a range of 1,255 up to just over 10,000, sorry, just under 11,000, and a standard deviation of just over 1,100. Radiographs were then converted from 12-bit to 8-bit images, and the 8 texture analysis methods were used to produce 44 texture parameters, which were then fed into the machine learning algorithms. So of those 44, 5 were based on first order statistics, 11 on spatial grey level dependence matrices, 4 on grey level difference statistics, 7 on grey level run length image statistics, and 5 on neighborhood grey tone difference matrices. A one-way analysis of variance with 2 keys post hoc test was then used to allow the study authors to compare the mean values of these parameters, and P was set at 0.05 for this study. All of the parameters were then fed into the machine learning algorithm, which was an artificial neural network. 70% of the data was used for training the algorithm, and then 30 for the test data set. So that corresponds to 261 samples versus 139. So textural features for each of these 4 lung patterns that were included in the study were then used to train the algorithm, and classification performance was quantified using using an accuracy value and also area under the curve, or area under the receiver operating characteristic curve, but area under the curve. 40 of the 44 parameters showed statistically significant differences, 4 didn't. 4 of those were with a p-value of 0.05, which had been set as the acceptable level for the study. 36 of those outperformed that and had p-values at less than 0.001. And then in the post hoc test, 13 of those 40 parameters showed statistically significant differences between all the lung patterns, so each from each other. However, the p-value and confidence intervals are not presented for that data. So on the training data, accuracy was 99.1% and AUC was 0.98 or greater than 0.98. For the test data, accuracy was 91.9% and area under the curve was greater than 0.92. So there is a slight drop in accuracy and area under the curve for the test data, but that's not unusual. And there's just a table showing the results that they achieved for the 4 different lung patterns, P1, 2, 3, and 4, giving accuracy and area under the curve values. And you can see there's a bit of a drop from the training data to the test data, as we might expect. So the discussion for this paper was fairly thorough and sensible. They noted that previous studies have concentrated on detecting disease, so the presence or absence of disease rather than the classification, and they were using much smaller regions of interest. This study instead aimed to classify specific lung patterns into 4 groups and used larger regions of interest in an attempt to do that. The vascular and nodular interstitial patterns were excluded because there was a feeling that it would be very difficult to reliably get the textural pattern analysis data for different vessels, so arteries and veins, and also for vascular branching. And with the nodular lung pattern, nodular interstitial pattern, the localization of lesions, if nodules were missed and not excluded in regions of interest, then that would have produced textural pattern data that essentially represented normal lung, which would have skewed the data, so that they would have ended up with results equating to P1, which is the normal lung pattern, whereas in fact, a nodular lung pattern would have been present. So the nodular interstitial patterns were excluded. As I mentioned earlier, also the mixed patterns were excluded. The rationale for that being that it would be potentially difficult to decide which was the most important lung pattern, the most significant lung pattern, and also, again, for the textural analysis, it would be difficult for the statistical analyses to give reliable textural pattern data where you had different patterns overlaid one over the other within a given ROI. It's possible that using too many parameters with a machine learning algorithm can reduce rather than increase the accuracy of the machine learning algorithm model, because the data attempts to be too closely fitted to the machine learning algorithm attempts to be too closely fitted to the data, and data inherently has natural variation through sort of random events. And if you attempt to model that too accurately in your machine learning algorithm, then you will reproduce those what were random variations in the test data. However, they did do a pilot study prior to this main study, and they found that actually the accuracy of each of the groups of parameters, so the ones I listed earlier where they got those 8 textural pattern groups, actually were lower, quite significantly lower, in the 60%, compared to combining them all together. So in this particular instance, they were happy combining all of those parameters together and using all 44 of them. So the results from this study, the authors claim, suggests that the model can accurately detect differences between the radiographic lung patterns under investigation, and that seems a reasonable conclusion to draw. Their statistical analysis using one-way analysis of variance is reasonable. However, the Tukey post-hoc analysis should produce confidence interval data, which they haven't provided. So it's not possible to draw firm conclusions when the data is not available. They do acknowledge several significant limitations to this study, probably the most significant of which is that they acquired all of the images for this study using a single acquisition device, and all of the parameters that they fed into their machine learning algorithm were obviously produced or arrived at based on images acquired by that one device. And there's no evidence as yet to suggest that those parameters and the results produced by the machine learning algorithm would then produce similar results had the images been acquired on a different system from a different manufacturer. So area for further research there to see if this model has application on images that have been acquired by other equipment. They also note that by converting a 12-bit encoded radiographic image to 8-bit, there's a 16-fold reduction in range of intensity information, and it's possible that that has hidden significant grey level textural information from the machine learning algorithm. And they speculated that there may be a change in performance by using the original 12-bit data, but that it's impossible to say whether that would have improved or reduced the accuracy of the results. They also suggest that given that any lung patterns or any radiographs in which the lung patterns couldn't be agreed upon by the radiologists, so the gold standard, may have biased the data that was used towards cases that were perhaps considered or would be considered more obvious, where there's maybe less ambiguity as to which pattern is present, and therefore the application of this data to real-world cases may be limited, though they note that this is a potential area for further research to see how the algorithm's performance would be altered by including those radiographs. They also note that they have made no attempt to evaluate the reproducibility of the radiologist's evaluation of the lung lobes, so to ensure that they classify each of the lung lobe patterns the same each time, or whether, had they looked at the data again at some other point in time, they might have classified them differently. So essentially the quality of the gold standard is potentially up for debate. They've also noticed that only one of the 3 radiologists then went ahead and selected the regions of interest, and it's possible that the results may have been different if one of the other radiologists had selected regions of interest, or of course, if the three of them had done that in agreement with one another. So the conclusions the authors pull out from this study, and I quote this verbatim: a number of texture parameters showed significant differences between the patterns. The developed artificial neural networks demonstrated high performance in discriminating the patterns. Texture analysis and machine learning algorithms may have potential for application in the evaluation of medical images. This seems a fair and reasonable conclusion. However, they don't really make any mention of clinical application in the real world, other than their acknowledgement of the fact that the mixed or less obvious patterns may be harder for the algorithm to detect, and therefore certainly the results that were achieved on more real world data where they haven't been selected so carefully may be different. That may improve the performance, it may reduce it, they don't know. The other thing they draw attention to, and that's worth noting, is that there's no attempt to incorporate clinical history or signalment or clinical signs into this equation, if you like, so that the radiographic information is being looked at completely out of context, whereas of course a radiologist would be able to look at the images in the light of their knowledge about the clinical symptoms, the clinical history of the animal, its signalment, and so on. So all in all, this seems like a reasonable study, effectively in the context of a pilot study, as a proof of concept that the machine learning algorithm is able to differentiate the lung patterns, at least in certain situations and at least in certain conditions, and that conceivably that may then have application in clinical practice, but that a lot more work is needed to validate this particular algorithm in some of the more challenging situations, and in particular on equipment that is not the same as the equipment used in this particular study. Thank you very much. Thank you for listening. If you have any questions, we will be running a live Q&A session later in the week. So please feel free to sign up to that, and we will do our very best to address or at least discuss any questions you may have. Thank you very much for listening.
Okay, hi everybody, and welcome to this month's edition of the IMV Imaging Journal Club. My name's Sam. I'm one of the vets here at IMV. I've got my colleagues Hannah, who we can see on camera with us as well, and Ben, who we can't see on camera because he's having some technical issues today. Ironically, when we're looking at a paper on machine learning and artificial intelligence, we have technical difficulties, but that's the way these things go. So thanks to everybody for kind of tuning in and joining us tonight. We're discussing Ben's paper from early in this week. He went through on the IMV Journal Club, which was on the classifications of radiographic lung patterns using machine transfer learning. So really something that's going to be the future and a very interesting topic. It's great for everybody to join us tonight and to participate. We obviously were driven by the questions that people asked after the first showing, but if anybody does have any questions they want to ask while we are chatting and discussing the paper, feel free to pop them in the question bar on the menu for the webinar as well. So we'll get started with one of the first bits that we were asked kind of around Ben's paper as well. That was about the implications of the compression that was applied to the radiographs. So if we think back to Ben's paper, they were looking at the sort of using this machine learning transfer learning program to look at lung patterns and compare that to the sort of accuracy of clinicians as well, and they used some compression before analysing the radiographic areas of interest that they checked too. So what did we think about the sort of implications of compression that were applied to that data before the analysis was performed?
I suppose I ought to take this one, Sam. Apologies to everybody that I don't have video, as Sam says. Rather embarrassingly, as a technology company, I'm having technical difficulties, so yeah, apologies for that. Yeah, it's an interesting question, and it's something I pointed out in the discussion, both in the presentation and in the written summary, which we've shared as well. I guess the answer is that we don't know, which is kind of maybe not terribly rewarding or informative, but and this is one of the issues with these sorts of technologies at the moment, you know, and no doubt this will improve, but because of the nature of machine or AI in general, but machine learning algorithms in this context, they're a little bit black box, and so it's quite difficult to know exactly what it is that the algorithms are picking out as features to differentiate these or to classify these lung patterns. Consequently, it's difficult to know what effect compression would have, and also to sort of expand on that slightly, we don't know what compression algorithms are used, so there's kind of a double blind, if you like, issue there. Now, I'm assuming the authors know what compression algorithms were used, though they didn't share them, and in some ways that in its own right would have an effect, but just in a more kind of general sense, compressing data will inevitably change the image in some way. We may or may not be able to perceive that with the human eye, depending on what the compression was. However, it's not unreasonable to assume that the model that they've sort of developed for this paper would be able to detect some kind of change. The issue is that with any any modeling, any statistical modeling, and obviously machine learning algorithms are essentially just that, is that you need to fit the model closely enough to the training data to be able to truly learn from real things in the data. But if you overfit it, obviously in data collected from any kind of experiment, you will have random variation, noise, if you like. And if you overfit noise, the whole kind of point of random variation is it's random, so it's not going to be the same next time. So if you've overfitted your model to the random variation that occurred in your training data set, then your model is going to be less accurate for other data, for test data. So it's possible that compression would improve the accuracy, because to some extent you would effectively be minimizing the effect of noise by compressing the data. But equally, sorry,
could you use detail in that compression? So if you've lost the detail in the compression, the patterns might be more generic patterns. You might not pick up on things quite so much.
Exactly that, yes. And so you could obviously, and perhaps the more instinctive feeling is to assume that because you're losing information, you're going to somehow make the model less accurate, and that indeed could be the case. Or it could not be, and the problem is this paper doesn't address that issue. And to be fair to the authors, they acknowledge that. However,
it goes back to that thing: you can have too much data or not enough data, but you've got to be using the data correctly. So it depends, as you say, is it noise that you're losing, or is it detail that you're losing? And as you say, it's in this paper.
Correct, and they sort of address a similar issue in acknowledging the fact that forgive me, off the top of my head, they measured 44 parameters of texture pattern analysis. I think it was 44, and they weren't quite sure whether that would be too many, because again, in the same way, or in a similar way, if you're assessing too many features, you may be essentially overfitting the model to the test data. As it happens, they did address that within the context of the paper, or sort of, in that they'd done a pilot study prior to this paper, and they'd assessed the accuracy of each of the different groups of texture pattern analysis techniques on their own, and each one was significant. It's about, from memory again, about 25 or 30% less accurate. So they've addressed that, but it's that same concept that adding more data or more granularity doesn't necessarily improve things. It might, and it might not. And the problem is, off the back of this paper, they basically don't know. So, I mean, I certainly wouldn't profess to be knowledgeable enough about image compression to in any way suggest I would know, even if they had shared the data, about what compression algorithms they used, what effect that might have. But I think for sure further testing or work would be required to either not compress the image or to test different compression algorithms, maybe compare it against the control, if you like, control of non-compressed data, just to see what effects it would have. And as I say, to be fair to the authors, they did acknowledge that.
Okay, thanks, Ben. We had the next question that came in was just asking about whether, because they looked at some sort of specific radiographic lung patterns, is whether this kind of algorithm or sort of machine learning model could be expanded to detect other patterns. The ones that they sort of left out were nodular interstitial ones within the paper, and in the paper they also mentioned other patterns that they deliberately excluded, like vascular ones, and so do we think that this kind of this type of analysis or type of method could be expanded and used to look at these other patterns?
It seems likely, and certainly if you look at the literature in the human medical diagnostic imaging field, there are actually quite a few papers. So in fact, there's an entire sort of like subset of techniques in human imaging, human diagnostic imaging, called computer-aided diagnosis, CAD, and there's a real hot topic of research, and there are numerous papers published looking at, for example, as you said, Sam, nodular interstitial lung patterns, and using algorithms modeled to diagnose those. So clearly there's evidence, albeit not from the same species that we're dealing with, but evidence to suggest it can have uses. So it seems likely for sure that would be expanded. Sorry, Hannah, you go ahead.
I was going to say, in theory, it makes sense, doesn't it? If we have enough data sets of those specific patterns, we can to see that pattern, not this pattern. I know in the vet there is a study group looking at doing the same idea, but in the veterinary world, but looking at skin lesions. So they're just having to feed it enough data so that it knows that when it looks at a photo, that whether it's a diagnostic kind of skin lesion or not. So it's the same principle. So you would think it would be able to, as I say, have parallels. And if we've got the parallels in the human world going on, that it's potentially an area that could be expanded into.
Yeah, and that's an interesting one, because in that instance, they are taking what is effectively a region of interest, as per this study, in the context of a photograph, because the medical photography department, in hospitals will be obviously, framing a photograph such that a lesion is kind of front and center, so to speak, and is obvious in the image. I have to confess to not having particularly read the literature about those studies, though I'm aware that I think actually skin or the dermatology photography was one of the earliest imaging modalities that was to which machine learning algorithms were applied, and I from what I understand, those algorithms very rapidly became quite significantly better than dermatologists at assessing malignancy outside the context of a biopsy, just essentially visually. And to that end, actually, it seems surprising. I just thought it was a bit odd that they eliminated nodular interstitial patterns. I appreciate their rationale was, well, you might have, if you had a region of interest that didn't have a nodule, essentially it would be normal. But then they were selecting the regions of interest, so why not select region of interest with the nodule in it? I guess then, because the regions of interest are quite small, it would then bring into question, well, where do you put, if the nodule size is sufficient, that the whole region of interest could either be nodule or normal tissue or somewhere in between, where do you then select the region? Do you aim for a region of interest that's like half and half lesion and normal tissue, or what do you do? So I can see the limitations, but equally there are, as I say, there are numerous studies published in human medical diagnostic imaging that use similar texture pattern analysis techniques to diagnose classify nodular interstitial patterns. So yeah, I find it hard to believe it will not be extended to the veterinary market or the veterinary field. It's just inevitably, an awful lot of what goes on in the veterinary research field is just that bit behind. So maybe it's just a case of time.
Okay. Yeah, I think that's quite a neat sort of segue into the next bit that I thought would be good to talk about, is that ideally, without getting too bogged down in a wider discussion of AI, is maybe how we think these algorithms and this machine learning will kind of affect and be implemented in thoracic radiography and radiology kind of going forward. Sort of what sort of potential can we see in this for this specific area, and how do we think it's going to potentially work in the future, I think, for our thoracic radiographs? I don't know if you guys have any thoughts on that.
I mean, I suppose from my perspective, the obvious end point, if you like, or sort of ultimate goal is you don't want a technique which requires you to sit and highlight regions of interest, because ultimately, that as clinicians, that's not how we work. You don't look at a radiograph and kind of subconsciously pick out 30 pixel by 30 pixel regions. Clearly, I know that seems a little bit trite to say, but you don't. That's not how you do it. You look at the bigger picture. They obviously slightly kind of tangentially addressed this in the paper, in that they said, this clearly is limited compared to a radiologist, in the sense that the radiologist can include previous exams, they can include clinical history, signalment, and so on, and obviously all of that, and as we all know, will undoubtedly affect your judgment of what you're seeing, as indeed will your experience, and if you like, predispose you to already having certain judgments in mind, and then again subconsciously perhaps, but you're then making this decision of which pigeonhole do I then say I think what I'm seeing fits into, based on the other previous stuff. So clearly that's missing. That's obviously a little bit different in the sense that that's data that's not image related. But if you just take the imaging bit in isolation, as a vet or veterinary radiologist, whatever you are, you'll look at a radiograph and you will look at the whole thing. And okay, you might not necessarily be interpreting your image of a lung pattern based on what you can see through rib shadowing or a cardiac silhouette. Fair enough, you are looking at the lung field, but nonetheless, you're looking at the whole radiograph, and the lung field kind of has a single, if you like, a single entity, or at least as a whole. So I suppose that has to be the end point, doesn't it? Of getting to a point where a model or an algorithm can take just the radiograph, and you don't need to sit there and select regions of interest. And also, I guess, classify not just the patterns, but but then potentially differential diagnoses. Now, I accept that strayed into what we were talking about a second ago, or what I was saying a second ago, of incorporating then clinical history and signalment and so on. But I think to my mind, that's where it's got to go eventually.
I agree. I think it'll be where it will potentially develop is helping us as a diagnostic tool. I don't think it's going to replace a vet anytime soon, because there's the experience, the knowledge, as you're saying, Ben, like standing back, looking at the patient as a whole. I think this technology will be very good at developing to look, as you say, not that we're having to necessarily select like that 30 pixel per 30 pixel area, but actually being able to assess a radiograph and say, with X amount percentage certainty, it is this pattern, which is therefore, or this pattern, or a mixture of this pattern. Therefore, these are the differentials that are more likely. It will help sort that differential list, but I don't think we're anywhere near where it will be like, okay, this is it, this is it. It might be able to potentially then develop into advising treatment plans, but the whole, it's again, this is a potentially bigger discussion that you could have on AI going well beyond this. It hasn't got that kind of, it's not intelligent enough, this specific kind of AI, to then doing correlation and causation and what is causing the change in the pattern on the radiograph, and doing that step back. But definitely, I think there would be it would be a useful tool to have in our arsenal, to be able to define exactly what that lung pattern is, because I've stood there in front of radiographs and you're there going like, oh well, is it this one, is it not, is it that one? And particularly maybe for vets we haven't got enough experience using the technology as a tool, but not always having that awareness not to fully rely on it either.
Yeah, I think that's a really good point. Like I totally agree. I think it's probably in the quantification to some degree of what patterns are there. Like I'm totally with you. You have that moment where you look at radiographs and there's a pattern there, but exactly which one can be sometimes quite difficult, especially as quite a lot of the time they're often mixed, aren't they? Like even in those classical kind of disease presentations, you often still got a mix of patterns, that you'll have a bronchial and an interstitial pattern, or you might have an alveolar pattern with other changes, especially with dogs, where you get changes with age-related change within the lungs and things as well. They all make it really difficult, but I could certainly see something like this being implemented through your digital radiography, where it does look at the whole thing, and maybe at the end of it you've got, like you said, Hannah, a percentages, so maybe a percentage of this pattern in the lung for the percentage of that pattern, or even that you could optionally put maybe some kind of, I don't know, like a graphical overlay on the radiograph showing where the areas of pattern are, to at least highlight areas of change or kind of help you. But I just, I totally agree. I can't see it ever getting to the point where it would replace the vet at the start of it, because exactly as you said, the signalment has such a big impact on that. There's a big difference between what you're going to consider for certain patterns in a young animal versus an elderly one, and in certain breeds and things as well. So I don't think it can necessarily change that, but I certainly think it can help, because it can quantify the amount of change, and that has a lot of more implications on once we know sort of what's within normal ranges, what's within tolerances for sort of ages, then it has a bit more potential to then lead people on to the next diagnostic steps, because you have that possibility to say, well, we know at this one these are the likely things, so it's time to do a bronchoalveolar lavage, or it's time to do another sort of test. So I can certainly see it being really useful, and kind of almost giving you that quantification, rather than you kind of going, well, there's a bit of interstitial pattern here in this area, and there's maybe an alveolar bit over there. I could sort of see it helping from that side of things.
It's interesting how in this paper at the moment, like they didn't assess the mixed pattern. I assume like the more layers you put onto it, you know, the more you've got to train that machine to differentiate between like this is this, oh, this is, you end up kind of, the amount of options there are kind of duplicate when you're putting different, I think I need to go look at my stats, but it's like, I'm sure it's like to the powers and things like this if you like cross two of them together. So yeah, I like the idea of the visualization, and like being like just like highlighting the chair radiography.
I'll get it patented immediately.
Yeah, quick, get it on, get it down.
Not that I know how to do anything with computers or AI, so it's I'm slightly scuppered on that point really as well. But yeah, no. So
this does also, and the risk of sort of digressing into wider conversations about AI. I think there is a general perception or fear, maybe is a bit strong, but we don't want AI to steal our jobs. Let's be brutally honest, that is not going to happen anytime soon. Maybe in the lifetimes of our grandchildren, who knows, but like it isn't going to be happening anytime soon. There's huge limitations to these techniques, and in the same way that I don't know, if you just talk about I suppose I'm talking from a biased perspective here, but you just take ultrasonography and say farm animal repro, it might have seemed like the devil's magic, in the early days, and like it somehow was going to kind of rob vets of their expertise, and anybody could wield an ultrasound machine over a cow's reproductive tract, and no longer would you need the vet's expertise. But it's, if you actually step back from this and kind of think about it, it's so far from the truth. It's essentially another diagnostic tool, just like another lab test is. When a lab test comes out, it adds extra information to that kind of diagnostic toolbox. Yeah, but we're so far removed still from any kind of replacement of the clinician. It just takes away, if anything, it takes away the, perhaps for want of a better word, the drudgery, and you become more of a kind of sense and fact checking device, if you like, and a decision maker based on information, without having to do the kind of you know, the so much of the sort of that kind of tedious assessment. I think if people can view these techniques with more of a mindset of they're these sort of tools to help, and see them in the limitations that obviously implies, then that's when to some extent that's when it's most exciting, because actually, let's be honest, some of the tasks that the AI algorithms can be applied to are exactly that. They're boring, and actually having something that kind of not decides for you, but hints at what's going on, and then you say, yeah, I think that's fair, is actually quite useful and quite appealing.
Takes away some of that repetitivity of it. Is that even the word? Repetitiveness of it all. But also, I think you kind of touched on as well, like not shying away from it because through fear essentially, and actually trying to step back and think of it, how can we use it as a good kind of tool? You know, if you can train a machine, you know, to look at thousands and thousands of pieces of data, like how long would it take a clinician to get at that kind of experience? And not only that, the machines aren't going to be biased by anything. They're not going to be tired. They're not going to be grumpy. They're not going to be overworked. They're just going to learn. And therefore, you know, it's going to be much more accurate in some days. It's going to be able to help you, you know, improve your patient's kind of care.
That's a hugely important point, actually, that you make there, Hannah. Where machine learning has an advantage over humans, because whatever potential deficiencies there may be in accuracy, particularly when you take that sort of bigger picture concept into mind, obviously there are weaknesses, particularly at the moment and maybe for the next couple of decades, in machine learning, but where it has a huge advantage is it never gets tired, it never gets fed up. So you all of a sudden eliminate any kind of human error, which actually, I mean, I wouldn't have a clue about human error associated with diagnostic imaging specifically, but if you look at any area where I suppose kind of health and safety is a concern, if you like, so you know, car crashes and aeroplane crashes and mistakes in hospitals with regards mistreatment and all those sorts of things, almost everything comes down to human error, and an awful lot of that is based upon fatigue, essentially, whether that's fatigue in the sense of you haven't had enough sleep, or whether that's fatigue in the sense of you've looked at just too much of whatever it is you have to look at, be it the road in front of you because you've been driving for hours or whatever it might be. The vast majority of kind of, if you like, issues or inaccuracies or whatever you want to call them are caused by human error because of fatigue of some kind, and machine learning algorithms don't have that problem at all to any extent ever, and that in its own right is hugely significant.
Yeah, that's great. Yeah, no, I mean, it's certainly an area that holds huge potential for the future, and I can certainly imagine us seeing more of it going forward in the veterinary industry as well. I think that's all our kind of questions. I don't think anybody's posted anyone through the course of the session, but so it just probably remains for me to say thank you very much, everybody, for joining us. I hope they've enjoyed this edition of the Journal Club and our discussion. Look out for future editions coming up, and we'll be putting those out on Facebook, so it'll be different topics each month, and it's always great to get everyone's participation and get your interaction and questions. Don't be shy, and we're always happy to hear from everybody, and we'll hopefully see you in the future. So I think it's probably time to say goodbye for us. So we can say goodbye from Hannah and Ben, to everybody who's tuned in tonight. And before I worsen the fear of AI by making jokes about Skynet or Isaac Asimov, I am going to sign off as well. So goodbye, everybody. See you later.
Cheers. Thanks very much.
Bye.
Yeah.